Thank you very much for the chance to come talk to you about cardiac surgery. So, as Mario and Santiago said, really everything we do now in surgery, we think in the back of our mind, what transcatheter options does the patient have today, and what do they have down the line? And what options do we have to treat them surgically up front, and maybe treat them with a transcatheter option down the line? So, I'll talk about basically three things we do surgically: valve repair, valve replacement, and then sometimes your valve's not working, but it's not because there's anything wrong with the valve, but actually you have some thickening of your heart muscle in the wrong place, and it makes your valve leak. So we'll go over all three of those. So this is a pretty standard mitral valve surgical patient. This cord has ruptured from his mitral valve, and so this, as you can see, it's flailing up into the left atrium. So this is severe chordal flail and mitral regurgitation. So this is a pretty standard patient we see. So one option would be to put a clip on it like you've seen before, but another option is to repair it surgically. So what we do is take these part out. So usually it's just one cord, a small segment of a large valve that's ruptured. So if it's just this little area, we'll cut that area out, sew it back together, put a supporting device around the whole valve, and repair it surgically. So this is what it looks like typically, or surgically. So this is the supporting device we put on. This is your anterior leaflet of your mitral valve and the posterior leaflet. So go in either through the front of your chest or through the side of your chest and repair your valve. This is a patient who has severe aortic valve leakage, not because their valve is diseased, but because their aorta is severely enlarged. So this is your ascending aorta. To give you a sense, this is your descending aorta. So the ascending aorta, where the aortic valve sits, is severely enlarged. So the leaflets aren't able to come together, they're not closing well, and the valve leaks. So instead of replacing the valve, what we can do is just replace this aorta. So here's what your valve looks like. This is a native aortic valve, and we've cut out all the aorta and replaced the valve inside that aorta. So you can avoid all the complications of valve replacement, taking Coumadin, having valve degeneration over time by saving the living valve. So why repair a valve? Often we can prolong your survival, help you live longer, provide better durability than a prosthesis, and often avoid blood thinners like Coumadin. One of the newer valves we're using is the Edwards Inspiris valve. So this valve is built specifically to undergo a transcatheter valve replacement down the line. So oftentimes, depending on multiple factors, your age, how big of a valve we get in, these valves tend to last somewhere between 10 to 20 years. So if you're 50, 60, don't want a mechanical valve, don't want to take Coumadin, we'll put in a valve like this that we can put in 10 to 20 years down the road. When it degenerates, we can likely put a transcatheter valve inside that valve. The valve will expand. We can get a nice big valve inside your surgical valve. The other option we have is mechanical valves. So these valves don't degenerate over time. This is an example of an aortic valve, an example of a mitral valve. So these are discs. There's no biological properties to them, and they tend to stay open forever. We tend to put these in two subsets of patients. So one, young patients in their 30s, 40s who really can't be undergoing cardiac surgery every 10 years because they'd end up with 5 or 6 heart surgeries. So that's one option for them. The other option is for people who are already on Coumadin, who just want one valve. They know they need to be on Coumadin, so oftentimes we'll put a mechanical valve in. And you can see that this is comparing mechanical tissue and valve repair, so for the mitral valve. So at 10 years, if we put a tissue mitral valve in because you don't want to be on Coumadin, they start to fail and you need a mitral reoperation. This is repair and mechanical valve. So you get essentially the same result for a mechanical valve that you will get for using your native valve and repairing it. So why surgically replace and not get a transcatheter replacement? The long-term durability of mechanical valves. Mechanical valves can't be placed through your groin, have to be placed open surgically. Often patients have more than one valve that needs to be treated. We can treat more than one valve at the same time. And often, for whatever reasons, patients are unable to undergo transcatheter valve replacement. So lastly, this is a patient who has a valve problem, not because their valve is diseased, but because they have some muscle thickening in a bad place. So this is your mitral valve. You can see you have significant leakage across your mitral valve, but the problem is his muscle, his heart muscle, right under his aortic valve next to his mitral valve is too thick. So what we can do is go in. This is a view of the muscle through your aorta. This is your aortic valve that's being separated. This is your mitral valve that's narrowing the area out of below your aortic valve. And we can cut that muscle out. And it looks something like this. This is typically what the inside of your heart muscle looks like. And this is what it looks like afterwards. So as you can see, the mitral valve is not leaking at all, and we actually can do something to simulate putting you on a treadmill, stressing you in the ORs. This is while you're still in the operating room, before we've closed you up. We can see even when you exercise, your mitral valve still works great. So in summary, repair repairable valves when they're possible. When we're replacing the valves, we're considering mechanical valves or valves that can undergo transcatheter replacement over time. And patients with hypertrophic cardiomyopathy may have valve dysfunction related to the muscle that can be treated. Thank you.